This is Dr. Mariah Jegan, and my topic for the paper is abdominal manifestations of extranodal lymphoma. Extranodal lymphoma refers to the lymphomatous involvement of organs or tissues outside the lymphatic system and accounts for approximately one third of all non Hodgkin's lymphomas. The abdomen is most commonly affected region owing to the presence of lymphoid tissue within the GI tract and solid abdominal organs. Abdominal extranodal lymphoma may involve the GI tract, liver, spleen, pancreas, kidneys, adrenal glands, peritoneum, and mesentery, either as primary disease or as a part of disseminated systemic lymphoma. Radiological imaging plays a pivotal role in the detection, characterization, staging, and follow up of abdominal external lymphoma. Here we see multiple hypoechoic lesions within the kidneys and the pancreas and ileal interception. Here we see multiple enlarged mesenteric lymph nodes and extramedullary lesion. Extranodal lymphoma occurs in about 40% of the patients with lymphoma and has been described in virtually every organ and tissue. In decreasing order of frequency, the spleen, liver, GI tract, pancreas, abdominal wall, genitourinary tract, adrenal, peritoneal cavity, and biliary tract are involved. Extranodal disease is more common with non Hodgkin's lymphoma than with Hodgkin's lymphoma. Age related lymphoma and post transplantation lymphoproliferative disorder are more likely to affect extranodal sites. Diffuse large B cell lymphoma and follicular lymphoma are dominant histological subtypes. Mantle cell lymphoma, lymphoblastic lymphoma, Burkitt's lymphoma, and mucosa associated lymphoid tissue lymphoma, however, are more likely to affect extranodal sites. On imaging, CT is the principal imaging technique. However, evidence indicates PET CT is superior to CT in detecting extranodal disease in abdomen, especially in spleen and liver. The role of PET CT in low grade lymphoma, such as small lymphoma, is controversial. Liver and spleen. The spleen and liver are involved in 20 to 40% and in up to 15% of patients with lymphoma. The patterns of involvement include diffuse infiltration with or without organomegaly and focal nodules. FDG PET-CT is more accurate than other cross-sectional techniques. Focal hepatosplenic lymphoma appears as a circumscribed nodules that are hypoechoic, showing no posterior acoustic enhancement. On MRI, the nodules may appear as hypo or iso-intense compared with normal spleen or liver on T1 weighted images and hyperintense on T2. Here we see focal hepatosplenic lymphomas, which is indistinguishable from METs but are usually smaller and homogeneous and occur with extensive bulky coalescent lymph nodes. GI tract. Extranodal lymphoma in the GI tract occurs in 10 to 30% of all patients with NHL. The stomach, bowel, pharynx, large bowel, and esophagus are involved in decreasing order of frequency. The patterns of GI involvement include polypoidal mass, diffuse or focal infiltration, ulcerative lesion, or mucosal nodularity. The cecum and rectum are the most commonly involved parts of the large bowel. The patterns of large bowel involvement include bulky polypoidal mass, infiltrative tumor, and aneurysmal dilatation. Differential is gastrointestinal adenocarcinoma. In contrast to gastrointestinal adenocarcinoma, lymphoma is more likely to involve multiple and longer segments of gut and is likely to cause bowel obstruction. Here we see on CSCT nodular masses in proximal small bowel and mural thickening of distal ileum, and mesenteric nodes are noted. On the right, we see on CCT imaging circumferential thickening and aneurysmal dilatation of segment of distal ileum. Genitourinary system, renal involvement occurs in 3 to 8% of patients with lymphoma. The kidney is most commonly an involved part of the genitourinary tract. The patterns of renal involvement in descending order of frequency include multiple circumscribed masses, direct infiltration from adjacent nodes, a solitary mass, and isolated perinephric mass. Differential is transitional cell carcinoma and severe pyelonephritis. It will mimic diffuse renal infiltration by lymphoma. Extensive bulky coalescent lymph nodes and absence of features of an infective process are support of the diagnosis of lymphoma. The ureter is often affected by involved retroperitoneal nodes, but primary involvement of the ureter by lymphoma is rare. Transitional cell carcinoma may mimic bladder lymphoma. Rarely, patients with lymphoma have testicular involvement at autopsy. Here on CCT, we see multiple bilateral circumscribed low attenuation renal masses, and on ultrasound, we see multiple hypoechoic masses. Here also on CT imaging, we see soft tissue perinephric mass that partially encases left lower kidney without frank renal invasion. Here, testicular involvement is shown in this image. Pancreas. The pancreas is involved in about 30% of the case of NHL. The patterns of involvement include circumscribed mass and diffuse glandular enlargement, mimicking acute pancreatitis. Although bile duct obstruction may occur with pancreatic lymphoma, moderate to severe dilatation of main pancreatic duct, despite bulky tumor, is uncommon. A differential is pancreatic adenocarcinoma. Here on CECT, we see low attenuation tumor nodules within the pancreatic body, and on PET-CT, we see avid FDG uptake. Adrenal gland. The adrenal gland is involved in about 4% of the cases. Bilateral adrenal involvement occurs in approximately 50% of these cases. The patterns of involvement include round, circumscribed, homogeneous mass, and enlarged adrenal gland that maintains it. In this CECT, we see rounded, large bilateral adrenal tumors. Biliary tract lymphomatous involvement of the biliary tree is rare. The patterns include intraluminal polypoidal mass, a large mass replacing the gallbladder, and diffuse mural thickening. Differentials are cholangiocarcinoma. Here, on ultrasound, we see diffuse asymmetric mural thickening of the gallbladder, and on CECT, we see homogeneous soft tissue thickening of the wall of gallbladder. Peritoneum and peritoneal reflections. Peritoneal lymphomatosis is a rare clinical presentation. The patterns of involvement are discrete nodules and diffuse infiltrative mass and ascites. Exudative ascites from peritoneal lymphomatosis show high attenuation because of its increased protein content. Differential is tuberculous peritonitis. Here on plain CT, we see ascites with similar attenuation to adjacent muscle with linear bands of soft tissue attenuation. And on PET CT, we see avid uptake of FDG. These are my references. Thank you.